Doctor, we are live now.
Hello and welcome everyone for today's live webinar by Glaucoma Society of India. Today's webinar is on the Journal Club. We have two presentations. One is from Dr. R.Sharmila Rajendran from Aravind Eye Hospital, Madurai. He's a senior consultant at Aravind Eye Care System. Then we have Dr. Meenakshi Dogra from Glaucoma Fellow from Shankara Eye Hospital, Bangalore. We have mentor, Dr. Meena Gopinath Menon from Shankara Eye Hospital, Bangalore. He's a senior consultant at Shankara Eye Hospital. And we have Dr. Sushma Tejwane. She is the medical superintendent at Narayan Nethralaya 2. And we have Dr. Rajul Parikh, the director from Polex Glaucoma Eye Care Services, Mumbai. So without much of a delay, we'll go with the first presentation from Dr. R.Sharmila. The topic is on the experimental study designs. Over to you, Sharmila.
Thank you very much, sir, for that kind introduction. So I'm going to be sharing my slides now.
Yeah, we can see the slides. Make it as a full page.
Yes, sir. Yeah.
Yeah, all done. Yes.
Thank you. So this is in continuation with the previous journal club where we saw about study design part 1, which basically dealt with the observational study design. So this is going to be today's class on a lecture on experimental study design. So to just have some recap, so the study designs, clinical study designs are broadly classified as observational or experimental study designs, wherein the observational study designs are hypothesis generating studies, and they are again broadly classified as descriptive studies or analytical studies. The descriptive studies provide a description of the exposure and or the outcome, whereas the analytical studies, they provide a measurement of the association between the exposure and the outcome. And today we're going to be dealing about the experimental studies, which are hypothesis testing studies, and they involve an intervention that tests the association between the exposure and the outcome. So the experimental or the interventional study designs are again further subclassified as clinical trials, field trial, community trials. And the most important thing is the clinical trial. They are again classified into various subtypes like the randomized clinical trial, the non-randomized clinical trial, crossover trial, and the factorial trials. So I'll be dealing with each of these a little in detail. So first and foremost is the RCT. So the randomized control trial, it is the most authentic and I think the top part of any clinical trial. These can be simply defined as patients are randomly allocated to receive one of the two interventions. So these are generally experimental, and the intervention here is controlled by the investigator. And RCTs, as the name denotes, they always have a control arm. So randomized control trial where they have a comparative control arm with the intervention group. So if you look at this term as RCT, you have a group of patients who are randomly selected from a particular population, and they are randomly assigned to either an intervention group or a control group, wherein the intervention group receives the intervention or the experimental drug or a treatment that you're going to test, and the control group may just receive a placebo or just the standard of care. So what are the advantages of this RCT? If you look at it, it is the gold standard way of doing a proper conducted clinical study. It's very authentic, and you always have a comparable group. It also eliminates bias. It facilitates blinding, and the difference in outcomes are based only by mere chance. So basically, you do not get any difference in outcome other than that occurring by chance. And what purpose is served by this random allocation? So if you look at these randomized control trials, you have to select a group wherein the covariates are distributed equally across the groups at baseline, which is nothing but the group that you're choosing, and you're trying to put them into either an intervention or placebo. both of them should have an equal chance of going into either of the arm, either an intervention arm or a placebo arm, and all of their baseline characteristics should be matched. So that is what is important. And the risk of imbalance remains even after properly executed randomization. So look at this flow chart here, and you can see that I've chosen patients with non-arthritic ischemic optic neuropathy, wherein they are randomized to undergo a treatment intervention, that is with IV methylprednisolone for 3 days followed by oral steroid, which is the intervention group. And there is another arm where you do not give steroids and you just follow them up. So all of these patients are followed up at regular intervals of 2 weeks, 4 weeks, 3 months, 6 months, and 1 year. And the visual outcomes are measured over a period of time between the intervention group as well as the placebo group in terms of looking at how the outcomes are in improving the vision. How is randomization achieved? So once you know that you're going to go for an RCT, it is very important to give more weightage to how you're going to randomize patients. So there are 2 steps involved in randomization. One is generation of an allocation sequence. The second step is implementation of allocation. If you ask me in between both of this, which is more important, the second step is very, very important. So the concealment of allocation is very, very important. It should be very critical and it should be blinded. The investigators or the participants should not be able to know about which arm they're going to be allocated because this may produce a lot of bias. So what is random allocation? So the random allocation means that all the participants have a defined probability of getting assigned to a particular intervention. It could be either a placebo arm or an experimental study arm. Allocation is not determined either by the investigator, by the clinicians, or the participants. An allocation is not predictable based on any particular pattern. So the generation of allocation sequence. So how does this allocation happen? So this could be just by a simple randomization, just like how we have cricket matches where we just put a coin and toss. So if heads, it goes to one and tails, it goes to another, something like that. So it is just a simple randomization. And second thing is a restricted randomization where you'd have a blocking. It is done to ensure equal balance of arms are followed throughout all portions of the study. The third one is a stratified randomization. So here you randomize them based on covariates, like for example, sex, age, etc. So you choose a particular intervention group and you have to have an age-matched control group, which is also of the same sex or age matched with the intervention group. And then the randomization occurs within that particular straight. Now we'll move on to the concealment of allocation. So this concealment of allocation is really very, very important because it helps in eliminating bias in scheduling patients to a particular arm of treatment. Sometimes you may be, you may be by yourself, you might be thinking that, if you put these patients in one particular arm, it may be beneficial to them, so you would schedule. So this kind of eliminates all of that. So you do not have a role to choose which of these patients go into which arm because you already know that this would be of benefit to that particular patient. And so this also helps in having a more stringent study and outcomes, and there are lesser chances of errors with this particular type of allocation. So then came up the allocation concealment, which is done by SNOS, which is nothing but a sequential, numbered, opaque, sealed envelope technique of concealing the allocation, or it could be just a central allocation by a central randomization, wherein the group that is doing this allocation has no idea about the study or the type of outcomes that are going to be there. So they just randomly have a central allocation where they have numbering, and then these are given to the study team to implement it. Types of RCT. Now moving on to the types of RCTs. The RCTs can be classified based on how the participants are exposed to a particular intervention. So here it's very clear that this classification is based on how the participants are exposed. So based on how they are exposed, they can be again classified as 3 types of RCTs. One is a parallel trial. The second one is a crossover trial. And third one is a trials with factorial design. So moving on to the parallel RCT, which is a very simple randomized control trial. So here you see that there is a box which is just a sample which is randomly taken from a particular population, and all of them have a similar characteristics in that particular sample, and they are randomly assigned to undergo either a treatment or a placebo arm. So once they are randomized, and then you follow them up to see the outcome, and you measure the outcome preferably by keeping it blinded. So the assessors can be blinded to this and then analyze the results. So this is what is the simple parallel RCT. Now moving on to the crossover RCT design. Here again, how you identify the sample is all same as what was seen in the parallel study. So here you take a sample from a particular population which have a similar characteristics, and then you randomize them to undergo either a placebo or a treatment. So once you do that, you follow these patients, you measure the outcomes. Once the measurement is done, the outcome measurements are done with the placebo or the treatment, then you do a washout. So once you wash out, the effect of the drug or the placebo is totally washed out, and then you switch the treatments. So the one arm which received the placebo earlier would receive the treatment now, and then the one which received the treatment earlier would receive the placebo, and then you follow up these patients and you measure the outcomes. So this is a better understanding. I put this. So effect of glaucoma medication. So you take patients with primary open-angle glaucoma, and then you put them on two different types of drugs, drug A and drug B, and then you measure the outcomes. And after that, you wash out, and then you switch drug B to the first drug A group which received drug A, and then vice versa. And then again, you follow these patients and measure their outcomes. So in this way, what happens is there are two groups, and both of them undergo the same type of intervention at different time points of the study. So in this way, each group will serve both as a control as well as an intervention group. And depending upon the intervention, a washout period is also recommended. And this is generally preferred only for drug trials because you have a washout which is possible, and any surgical mode of treatment, it is not reversible. So you cannot use this for surgical assessment outcomes. Moving on to the factorial trial. Here you test two different drugs with independent effects, totally independent effects on a same population. So the advantage of this is you do two trials for the price of one. Any clinical trial, it includes a lot of manpower, money power, etc. So here you do multiple things in one particular trial. So you have four groups. One is drug A, drug B. Then you have one group which has both drug A and drug B. And you have the fourth group which does not have either a drug A or a drug B, which is mostly a placebo group. So this is with a simple example of age-related eye disease study. So you look at patients, you have around 5,000 odd patients with age-related eye disease, and then they divide it into three different trials. One is those patients who have only AMD amongst these, and then the second group is AMD and cataract because both of them are age-related, and the third group has only cataract. And then you take the patients who have both only AMD as one AMD trial, that is AMD with cataract is also under AMD. And then you take the other group which has cataract, like cataract as well as cataract combined with AMD is taken as cataract trial. And then you look at all of the different types of treatment options given for each of these. So in this way, you get multiple outcomes at the cost of one single study. Now, community trial. Community trial is basically a large trial which is usually done on large population in a very short period of time, cluster randomized trial. So here basically groups of individuals who are having the disease or do not have the disease are assigned to different intervention or experiment groups. And these groups are basically identified from either a town or a city, or it could be a certain group such as a school or a college, because they all have the same, they'll undergo the same intervention or the experiment. Moving on to the third part, which is the first I told about clinical trials. In that we had randomized trial, non-randomized trial, crossover, and the factorial trial. And then under the clinical, under the experimental study, the second part of the study was community trial, which I just explained. And the third one is the field trial, which is the last one. So this is basically done to identify a prophylactic measures. For example, you just look at participants without the disease and they're placed in different preventive intervention groups, and you'll find out which is the better one to prevent that particular disease. Example, interventions to a group such as a vitamin and follow through to measure the certain outcomes. So any kind of thing which is new, like vaccine testing, all of this can go into field trial. Now we'll move on to another type of classification. This is based on who knows what. For example, who knows about the intervention that is being assessed. So this can be classified as open trials, single blind trials, double blind trials, or triple blind trials. So blinding is a very important part of any randomized control trial, which it increases the authenticity of the trial, it increases the weightage of that study, and it is having the highest scoring for any publication also. So RCTs will have the highest scoring. So the relevant groups here may or may not have any knowledge of the treatment assignments. That is what is called as blinding. So what are the relevant groups? It could be the participant, it could be the investigator, who's doing the study, or the investigator who's assessing the outcomes, or a data analyst. So none of these people will be aware about the study. They're blinded to the treatment randomization or the treatment groups. Open trials are all participants and investigators. That is, everybody knows about what is the intervention that this each particular patient is getting. Like, it can be like medical versus surgical. Here you cannot do any blinding because you know that one arm is just going to have medical treatment, other arm is going to go for surgical treatment. Now, single, double, triple, and beyond. So this kind of blinding is again depending upon which group of people are blinded to that study. For example, if it's single blind, it is just that either the participant or the investigator who's assessing the outcome do not do the assignments. In double blind, two groups, that is both the participants and either the outcome assessors or the investigators do not do the assignments. Triple blind is more than this. Like all three different type of people are not involved in this assignments. So that is called as triple blind study. So in spite of doing a blinding, in spite of doing a randomization, there are still chances of bias that could occur at any point of time in RCTs. So it can occur during selection bias. That is because of lack of concealment of allocation or due to patients not following up for regularly and loss of follow-up, etc. That can cause selection bias. Information bias and participant response bias due to lack of blinding, outcome ascertainment bias, bias due to competing interests, and there can also be reporting biases like publication bias, time lag bias, etc. So bias can occur at any point of time, but the very important role of any investigator is to make sure that you take up all of this and you connect all of them and you do not have any loose ends and let the study go in a proper fashion. Last but not the least is, in spite of doing a good study, it is also important to understand whether that study is a good quality one. So there's something called as quality score approach. So they ask a few questions like this. Was the study described, it is randomized. Was the study described as double-blinded? Was there a description of a withdrawal or dropout from the study? So they generally give a score of 1 point for each yes for the above questions and 0 point for each no. In addition to that, they give 1 additional point each if randomization or the blinding method is appropriate, and they deduct 1 point if randomization or blinding is inappropriate. So this scoring is generally ranging between 0 to 5, and anything less than 3 is considered as poor quality study. And there are also several initiatives taken to improve the quality of reporting of these studies. I think many of you would be knowing about all of these guidelines. One is the CONSORT, which is Consolidated Reporting of Trials, Standard of Reporting Trials. And then the STARD, which is again Standard of Reporting Diagnostic Accuracy Studies. And there is STROBE, which is reporting of observational studies. There is PRISMA, which is reporting of meta-analysis of or survey. And then MOOS, which is reporting of meta-analysis of observational studies. So these are different types of reporting of studies. And one key important thing is whatever study we do, it is important to register it under the Clinical Trial Registry of India. So we have this online, which is a clinicaltrials.gov, and you have to give all of the information. Then you get acknowledgement for this. And once that is done, this has to be done in the beginning of the study. Sometimes people do, when they're going for publications, there will be a requirement from the journal asking for the CTRA. So this, if you do it retrospectively, you have to provide you cannot do it retrospectively because it has to be done for RCTs and ongoing prospective studies. So you cannot retrospectively give a date and then do this. So this covers the study designs in total from the last lecture as well as this lecture. I had tried to make it as simple as possible because it is really a very dry subject. And it seems very simple, but it is very easy to also forget all of these
Thank you
terms
so
and
much.
things. So it has to be continuously applied in clinical practice. Thank you.
Thank you so much, Sharmila, for the wonderful talk. We have the next presentation by Dr. Meenakshi Dogra. Is he okay with her presentation? Dr. Meena?
Yes, sir.
Okay. After her presentation, we'll have a discussion on both the topics. Yes.
Can you
Can
see
make
my
it as a full page.
It's done. Is it visible?
Yeah, we can see, but just make it as a full page.
Yeah,
Slideshow mode.
it's already full page.
No, the slideshow mode should be.
Ha, ma'am. In my laptop, it's in slideshow mode only.
Just go to your next slide so we can. Is it your slides are moving?
I'm changing my slides. Is it okay, sir?
We are still not seeing the changing.
It's not moving.
Moving.
It's moving
Yeah, no.
So
now.
slide
Just
Now you share again.
Yes, sir.
stop sharing and then restart.
It's fine now.
Can you just go to the next slide?
Yes, sir. I
Are you
went
there
to.
on the next slide?
No.
Yes, sir. Is it moving?
No.
Yeah, now it is moving. Yeah. No, you just go to your next slide now.
Is it moving now, sir?
It's not moving now.
Is it moving now?
Yeah, yes.
It's fine now, sir.
Just go ahead and then see one more time. You just try the next slide, and then if it is moving, yeah.
Go to next. Yeah.
Yeah.
Sure.
Yes,
Okay.
yes. Can you just make it as a full page? Try that.
If I'm making it full page, it's not moving somehow.
Or you just increase the bottom. You can see near
Yes.
the full page. Yeah, just increase the size of it.
Yeah, I think 90 is fine.
Yeah, please go ahead.
Okay. Uh, Good evening. Welcome all of you to the Journal Club. And firstly, I would like to thank my mentor, Dr. Meena Gopinath Menon, ma'am, for giving me this opportunity to present on this platform. So before going to the topic proper, I would like to give you an introduction, like why we have chosen this topic. So, glaucoma is a neurodegenerative disease causing progressive retinal ganglion cell loss, as we all know. The current monitoring tools for glaucoma are visual field testing, which is limited by patient cooperation, especially in elderly patients, and OCT, which is prone to artifacts and anatomical variability. And both are surrogate markers and less effective in early disease stages where damage may not be apparent. Thus, there is a clinical need for a novel marker for neurodegeneration in glaucoma that may provide more easily interpretable and reliable characterization of RGC health. Emerging technologies like detection of apoptizing retinal cells, which track real time RGC apoptosis, and photopic negative response via electrophysiology, which reflects the RGC functions. These are new, promising techniques but are not widely adopted in clinical practice. So, what are biomarkers? Biomarkers are basically biological markers. These are measurable indicators of a biological state or condition. Few commonly known biomarkers are HbA1c, which is a biomarker for long-term blood sugar control, specific antigen, which is a biomarker for prostate cancer. In our institute, we have done study on OCT biomarkers in diabetic macular edema, for example, subretinal fluid, presence of cystoid spaces in outer plexiform layer and inner nuclear layer, continuity of IS-OS layer, and presence of hyperrefractive foci. These are the few examples of ocular biomarkers in conjunctiva, biomarkers in glaucoma, and biomarkers in retina. So why we need biomarkers in glaucoma? In glaucoma, the only modifiable risk factor currently is intraocular pressure. A good biomarker in glaucoma could detect early retinal ganglion cell damage. It can predict progression, and it can guide decision making and improve clinical trials designs. It improves the clinical trial designs. Neurofilament light chain. So, neurofilament is a cytoskeleton protein which was studied as a marker of neurodegeneration in brain and spinal cord in various neurodegenerative disorders. These neurofilament light chains are released by the damaged neurons and get accumulated in cerebrospinal fluid and peripheral blood, and it can be easily quantitatively analyzed using a appropriate assay. These neurofilament light chains have been studied extensively, and few examples of their clinical utility are in Alzheimer's disease, serum NFL levels of change correlates with early and pre-symptomatic disease progression. In traumatic brain injury, especially in acute concussion stage, the serum and CSF NFL levels reflect injury severity and may decline over years post-injury. In multiple sclerosis, high NFL levels were linked to lesion load and future relapse risk. NFL decreases with treatment and indicating stabilization of the condition. In Parkinson's disease, serum NFL levels are elevated and it increases with time and correlates with clinical progression. So moving on to the article. So the topic of this article is to evaluation of serum and aqueous humor neurofilament light chains as a marker of neurodegeneration in glaucoma. This study was done by Jonathan B. Lin et al. At the Department of Ophthalmology, Harvard Medical School, Massachusetts, Eye and Ear, Boston, United States of America, with Department of Neurology, Massachusetts General Hospital, Boston, United States of America. It was published in Translational Vision Science and Technology, the article named Translational Vision Science and Technology, in their February 2025 edition, volume 14. The impact factor for this article for the year 2023 was 2.6. So their hypothesis was, as it was already known that neurofilament light chain is a promising biomarker for neurodegeneration, shown to be elevated in CSF and serum in various neurodegenerative diseases. And in the same group of researchers, in their previous study, they had proven that aqueous humor neurofilament levels are elevated in glaucoma patients compared to control, suggesting it as a potential marker of retinal ganglion cell damage. That study had around 46 control and 46 cases and 12 controls, and it has shown a strong correlation of aqueous humor NFL levels with glaucoma patients and with the severity of glaucoma. And they have also found that twofold increase in aqueous humor NFL levels were associated with 10.1% increase in odds of having glaucoma. So, aqueous humor collection is safe during ocular surgery, but it is not feasible for routine use in non-surgical patient. And hence, identification of a novel blood-based molecular marker for glaucoma would revolutionize our ability to care for patients with glaucoma in today's era of precision care. So the aim of this study was to evaluate the relationship between serum and NFL and to determine serum NFL is elevated in patient undergoing ocular surgery who have glaucoma compared with those who do not have glaucoma. So it was a single center cross sectional case control study. All the participants provided written informed consent. Cases were 110 glaucoma patients who are non-glaucoma patients undergoing treatment, and they are planned for glaucoma surgery as a part of their usual clinical care. Controls were 113 patients who were planned for normal cataract surgery. They do not have any known diagnosis of glaucoma or glaucoma suspects or ocular hypertension. They have included patients who have active ocular inflammation, retinal disease, or optic nerve degeneration from non-glaucomatous cases, any personal history of neurodegeneration, or if any patient reported unexplained memory loss or neurological symptoms such as numbness, weakness, or difficulty with ambulation, those were also excluded from the study. So preoperatively, in their preoperative holding room, they have collected blood sample before the procedure, and on the same day from the blood sample, they have extracted the serum and stored it at minus 80 degrees centigrade for further analysis. Before the procedure, mini mental status examination was done. It consists of 11 questions just to rule out if there is any mild cognitive impairment. Intraoperatively, around 25 to 150 microliter of aqueous humor was taken and immediately placed on dry ice and stored at minus 80 degrees centigrade for further analysis. Neurofilament light chains were detected using a single molecular array NF light chain advantage kit with an automated Sioma HDX analyzer. Sample size determination. So sample size determination was done before the data collection was started. For serum, to determine the appropriate sample size, and a priori power analysis was done. A priori power analysis is a statistical method to determine the appropriate sample size for a study before data collection, aiming to ensure sufficient statistical power to detect a meaningful difference between control and test. Factoring the influence of neurodegeneration from causes unrelated to glaucoma on serum NFL and accounting for the need to control for three covariates, that is age, body mass index, and MMSE score, it was determined to have 103 subjects each for control and test. So for serum, we had 112 controls and 108 cases, and aqueous humor we got from 79 controls and 99 cases. So how the analysis was done. So for Acosuma and for serum, it was done using a same Simoa kit. The samples were randomized across four plates with three analytical controls on each plate. Since Acosuma sample was less, it was diluted depending upon its quantity from 4x to 48x. And just to check if there is any effect of dilution on the sample, what they have done is they have taken three aqueous humor samples from glaucoma patients, and they diluted it 6 times from 4x to 48x, and they found that there is a linearity in the dilution. So they can safely say that there was no bias due to dilution. Lower limit of quantification was 1.38 to 16.56 picogram per ml based on dilution, and upper limit for quantification was 360 to 17,280 picogram per ml based on dilution. And since serum they got enough volume, the samples were diluted only 4 times. Lower limit for quantification was 1.38 picogram per ml, and upper limit for quantification was 1440 picogram per ml. So finally, after excluding patients which are below the lower limit of detection and all, finally for aqueous humor analysis, they got 64 controls and 96 tests. And for serum analysis, they got 112 control and 107 subjects. Other covariates collected for cases and controls were other covariables collected for cases and controls were sex, age, BMI, laterality, surgery type, glaucoma type, preoperative and maximum IOP, number of preoperative glaucoma medication, mean deviation on Humphrey field analyzer, and RNFL OCT, RNFL thickness using OCT. Statistical analysis. A priori power analysis was done using power package in R. Statistical analysis and data visualization was done using R version 4.4.1 and R Studio version 2024. To compare mean between the two group, Welsh t-test was done, and to determine relationship between categorical variables, chi-square test and Fisher exact test was done. Aqueous humor and neurofilament light chain levels were locked to transform to achieve normality. Moving on to the result. So, when demographic and clinical information with respect to age, BMI, and laterality, there was not much difference between the cases and control. In glaucoma population, there were more self-reported races like blacks and Hispanics. There were patients have wide variety of glaucoma and underwent wide variety of surgeries. Glaucoma was classified based upon ICD-10 classification into mild, moderate, and severe. There were 26% patients who have mild glaucoma, 28% patients had moderate glaucoma, and 45% patients had severe glaucoma. So, in a model controlling for age and BMI, log2 transformed aqueous humor NFL levels were significantly higher in glaucoma patients compared to controls, as we can see here. But in a model controlling for age, BMI, and MMSE score, the log2 transformed serum NFL levels were not different when compared with patients with glaucoma, when compared with cases and control. In a model controlling for the effect of age, BMI, and MMSE, there was a significant, albeit weak, association between log2 transformed serum NFL and log2 transformed aqueous humor NFL. So, what they found, one interesting finding they found was each twofold increase in aqueous humor NFL was associated with 4% increase in NFL. So, with increase in aqueous humor NFL, the serum NFL was increasing, but the increase is not much. It was with twofold increase, the serum NFL was increased only 4%. And they have also compared the log2 transformed aqueous humor NFL with other covariates like preoperative IOP, maximum IOP, mean deviation on HFA, and RNFL thickness. And here they found a moderate correlation between aqueous humor NFL and these covariates. And when they compared these covariates with serum NFL, there was no significant association between these covariates and the serum NFL levels. There was no association between the number of preoperative class of glaucoma medication with either log2 transformed aqueous humor levels and log2 transformed serum NFL levels. Moving on to discussion. So this study confirms that aqueous humor NFL levels are elevated in glaucoma patients controlled to healthy controls, aligning with their previous finding from both North American and European cohort. As NFL is released from the degenerating retinal ganglion cells, its presence in ocular fluid may serve as a molecular marker for RGC health in glaucoma. There was no significant difference in serum NFL in patients with glaucoma compared to healthy controls after controlling for the effect of age, BMI, and MMC score. The statistically significant association between serum and aqueous humor NFL suggests that there is some ocular contribution to the systemic pool, but as I have told previously, this contribution is not that much that it can be quantified. There was a statistically significant association between aqueous humor NFL and preoperative IOP and maximum IOP, similar to their prior study. And these are what they concluded that these are clinical factors that tend to be present in poorly controlled disease. And once again, these factors suggest that aqueous humor NFL may be more elevated when there is an ongoing RGC damage due to inadequate disease control and unacceptably high IOP. There was a statistically significant positive association between aqueous humor NFL and mean deviation and RNFL thickness. These findings initially seem somewhat paradoxical because it suggests that higher aqueous humor NFL is seen in patients with less glaucomatous damage. However, this association is likely because patients with advanced glaucoma may exhibit the floor effect. That is, there are fewer RGC remaining and therefore less NFL available to be released. The author did not observe a significant association between aqueous humor NFL and the number of preoperative class of glaucoma medication, which was in contrast to their previous study. But to confirm this, the cross-sectional study design is not optimal for testing this association. And as such, future longitudinal studies are necessary to directly assess whether there is a link between aqueous humor NFL and quantifiable RGC degeneration. So the strengths of this study was the robust studies size. The sample size was determined using a priori to identify a clinically meaningful difference between the groups. MMSE was performed to control for possible influence of subclinical cognitive impairment, and aqueous humor samples were taken during the planned ocular procedure. So patient did not underwent any extra intervention. Limitations of this study was it was the cross-sectional design prevents establishing a direct link between the neurodegeneration and elevated aqueous humor NFL. Although an a priori power analysis was performed, the observed effect size was smaller than is expected. and there was a significant racial distribution between the cases and control, which could confound the result. And racial diversity may influence the relationship between systemic NFL and medical conditions. So, taken together, this study serves as a validation that aqueous humor NFL shows promise as a marker of glaucomatous neurodegeneration. Serum NFL likely has a limited clinical utility given the relatively small contribution of the eye to the systemic circulation. Further longitudinal studies investigating the association of aqueous humor NFL and glaucoma progression are needed to determine the potential utility of aqueous humor as a glaucoma marker in clinical trials and clinical practice. So, in future, what is the translational utility of NFL in glaucoma care? So, if in future we are able to validate that NFL is a biomarker for neurodegeneration in glaucoma, it may be possible to use NFL to guide clinical decision making, like elevated NFL in patients with stable visual fields and OCT may indicate ongoing RGC damage, suggesting that these patient needs closer monitoring or treatment intensification. If patient has high NFL, they can be fast progressors, and these patients can be the ideal candidate for neuroprotective therapy trials. Including patients with elevated NFL in trials may shorten the trial duration, may reduce the cost, and increase the statistical power. So, thank you.
Thank you, Dr. Meenakshi, for a wonderful presentation. We have Dr. Meena, mentor, and we have Sushma and Rajul as the moderators.
Please,
We can discuss on both the topics,
please
Rajul.
stop sharing the Satyan. Just tell her to stop sharing.
Yeah. Probably we'll have the mentor first, and then we can have the discussion on both the topics after that.
Yeah,
Meena, yeah.
yeah, good evening, all. Thank you for this opportunity. So, we had taken this topic as she suggested in the introduction, because we are going with a lot of biomarkers in all the conditions. Even in eyes, we realize that the utility of biomarkers is becoming more and more. So that is one of the reason we found this study interesting to understand whether, we can do these kind of studies in our setup. So one of the interesting factors is our research director is a translational scientist from NIMHANS. So he also had given us a little bit of input in this study. So I think it's good to look forward to such kind of studies.
Okay. The only concern which I had was, how do you say that once you have an RNFL loss, that is because of glaucoma?
So this neurofiber light chain is released from this dead RGC cells. Now you cannot
That's fine.
100% say, but definitely we have to correlate with clinical decision also, like looking at the disk as well as other correlating um, factors like HFA and the OCT. Along with that only we can be using this, I guess.
That is okay. The only concern for me is the NFL loss can be like, it can be just non-glaucomatous in origin. It can be a glaucomatous in origin.
It can be
But
various reasons. Inflammatory.
there is quite a good number of reasons, and it can be a combination also. So in that case, just looking at this NFL loss and saying that there is a possible biomarker, that is the only concern I have. So over to Rajul and
Yeah, Sushma, go ahead.
yeah.
Yeah, so a couple of things I would just want to say when particularly this is a molecular biomarker. So one is that when we are looking at a molecular biomarker in vivo, in a study like this, where we are looking at an association with a particular disease. So we have to look at the linear association with the disease severity or progression or some quantification of glaucoma along with the amount of biomarkers you or quantification of the biomarkers that you see to say that it is associated with this particular neurodegeneration process. Secondly, whenever we have that kind of a in vivo association, we have to validate that biomarker with in vitro association with the same model, so as to be sure that what we are seeing in the clinic is also there in the bench. That is how it goes on when we talk about the molecular association. Although we are more used to the clinical biomarkers where we have a lot of other clinical things where we can establish that link. But when we are talking about the molecular biomarkers, the NFL light chain is associated with so many other diseases. So the amount of bias, noise we can have in the data can be tremendous. So that is why all molecular studies are considered uh, to have some strength if they have some second validation, which is usually done in vitro in these kind of studies. So that is something which was lacking in this particular article. It's a good study. I'm not saying, I think that is what I'm saying, that if we have to say that it is associated with the neurodegenerative process, particularly, or say in glaucoma, we have to have that kind of an association in vitro also.
Yeah, that is exactly I was coming to. Because any kind of a neurodegenerative disease,
The,
whether it
the
is
basic
orthograde or
assumption also
retrograde,
has a lots of problem, because the Alzheimer and other neurological disease where NFL is damaged, the same model like the other drugs like Mementin works very, very nicely in Alzheimer. The same thing didn't work in glaucoma patients. So the basic assumption that they are very similar, that also is a problem, that model itself. We don't know whether, because glaucoma is, I think, little different than only the neurodegenerative disease. So, and the other studies in 2020, it was published that they have taken the vitreous humor samples, not aqueous, and they could not find, in a sense, they say that it can be of the various reasons, not only glaucoma. This is why I was talking that, we are not sure whether it's really because of glaucoma or what. So that first we have to establish. So there is, I
yeah,
think, Sushma was talking about.
just let's listen to Dr. Meenakshi. Dr. Meenakshi, you want to say something?
Uh, Ma'am, you were talking about this power, so that's why they have done this A priority test, and the power was 80%. And just to make sure, like they negate the effect of BMI or age, they have like kind of like these are, because these are the independent factors which can increase NFL. So
Yeah, my dear, that is regarding the statistical power to see the
Yeah.
association. That is perfectly fine. It's a very good study that way. What I was talking about is in vitro validation.
So they have done in vitro also in rat studies and all, like, but it was done in vitro also.
They have
Like
not given any
Yeah.
reference.
in their previous study, ma'am, where they find out they have only checked the aqueous humor NFL. In that, they have given the reference of previous animal studies also.
Not animal, my dear, in vitro. That is different. Lab
Okay.
experiment, which establishes the same association. So you take a cell culture, which is neurodegenerated cells, and I mean, you expose it to the
Yes,
insult
ma'am.
and see whether the NFL levels are changing. That is in lab experiment, is what I was talking about. Yeah, I understand, you're right, that they have done the animal experiments, and that is how they have decided to plan this study, and which is a very good study. There are a lot of neurodegenerative markers that we have been looking, or people are looking, which are associated with glaucoma. And this is the beginning of how we would reach to the new therapeutic targets. So it's a very good study. I'm not.
Absolutely.
It's
Because
something
there is a lot of
we
new
have to
ways that we have to really
we
look
have to
into.
try,
This
because
is
sometime
absolutely
back
good
we were
one.
looking inflammatory marker also, especially in angle closure glaucoma. Nothing came out, but we
Yeah.
have to look to find something. But
In,
at this point in time, what you said that, what future we don't know. So you're talking about there are too many assumption in your last slide. We have no idea whether it would really be the case. So I think when you present too many assumption is not a good thing, because at this point in time we are not sure, because they could not um point out what they had previously suggested, the dose relationship. They failed to prove in their second study. The first study, they said that the number of medication has a relation with the NFL level. aqueous humor, which the second study failed. So at this point in time, I think the best way is to look for the progress. Uh,
Progress.
Take the patients and follow up the patients. I think that would be a very good study.
And
Progressive.
Some longitudinal studies.
short of that, even severity related quantification may also help. I mean,
Uh,
if you're looking at a severe glaucoma and the quantification of the NFL. One more thing I just wanted to point out, as Dr. Rajul mentioned about the vitreous and the aqueous. So now the movement of aqueous and vitreous biomarkers and cells is quite established. So aqueous is a good sample, even if you're looking at the neurodegenerative studies, because earlier we had that concept of that if you're looking at something related to retina or optic nerve, you should have vitreous samples. But now that part is already established that you can use aqueous as sample because there's enough crossover between the two.
Cross for you.
Yeah.
I just have one point to add.
Sharmila is there.
Yeah, I just want to add one point. So, like what Sushma was telling, I think Dr. Meenakshi also mentioned about the severity of glaucoma. What she was saying is actually, interestingly, the NFL level was not very high or indicative for severe glaucoma. And she also mentioned that it could be because of the floor effect. So a certain amount of RNFL is already lost, and so there was not possible to correlate that
Not
with
too
the
many RGC loss happening.
too many RGC loss, and there was a floor effect. That is why it was not there. So that could also be one way of saying that probably it could be a biomarker for picking up early or a moderate glaucoma rather than
Yeah,
to see the progression of the disease.
but the
That
problem
is
is that they didn't find in serum and do the aqueous step in every patient for the biomarker. I think it would be too invasive.
Yes, exactly. It'll be too invasive. I was also thinking whether Sushma can also answer this, like whether tear samples will anyway, because it is non-invasive, is there any way that we could near the aqueous um, sample, whether we could collect the tear sample because it is non-invasive?
Whatever little experience I have in looking at aqueous, tear, and blood samples, we have been trying to look at the association. So we have not been able to achieve tear and blood or aqueous and blood, because I think the blood gets diluted by so many other factors. Eye is a small area to have the influence on the blood. But in certain retinal disorders, we have definitely found a association between aqueous and tear, which is a good news. But till now, we have got that only for ocular surface diseases and certain retinal vascular disorders. For the glaucoma biomarkers, we are yet to establish a correlation between aqueous and tear so that we can, so that the sample taking is much easier and we can use it for the OPD patients as well. I really hope that we can do that someday so that it becomes much easier to use these biomarkers for looking at, severe progressors and things like that.
And
Sushma,
also
can you just give a gist of your study, which is that you presented during the AOS?
Okay, so that is related to the
I'm not able to recollect the entire stuff. Yeah.
Yeah. So I'll just tell in brief. So there are we looked at. Actually, the idea was to look at whether we have any association with severity, whether we can look at glaucoma, non-glaucoma, mild glaucoma, severe glaucoma, progressors, non-progressors. So we had strict definitions for each of them, and we looked at primary glaucoma only so as to avoid bias, and excluded all other patients. So when we looked at the aqueous, there were certain biomarkers like ICAM and NFL, which not NFL actually, ICAM, where we had associations with severity, with progression, and the severe form of the glaucoma, and non-responders to medicine and non-responders to surgery. So we came out with 4 molecules like that, which were actually fitting into the bad category of glaucoma. Just to simplify it, like when we have stable or people who respond well and people who are progressing or not responding to the medications, we could actually categorize into the two groups. So those four molecules were actually quite strong associated with poor disease or bad disease, or so that those can work as biomarkers where we can be more aggressive with the disease, do early surgery in those patients and things like that. But
Yeah, that is more practical.
yeah, so that will be more practical. But the only limitation yet that we have is that is all these things have been established in equus. So we are looking at that we can have this kind of similar kind of thing in tears so that it becomes easy. So as we do
Serum.
visual fields and OCT, we can do a tear sample also and can, understand whether it is going to be a progressor or a more severe form of the disease or non-responder. So that was the gist of that study.
Do you think that is going to be there, the serum as well?
No. Serum, I'm really not sure of, because the factors get much more diluted in serum, and there is lot of noise because of other diseases in the body like diabetes, hypertension, or anything. So there's a lot of noise there. So I'm not hoping for the serum. I'm just hoping if it can be done through the tears as well. So we are
Okay.
working on that. Hopefully in next few years we should be able to do something.
Yeah, that's good. So, any other comments on Sharmila's talk? Sharmila, you want to
No,
add
I
up
think she
something?
covered
Rajul?
she covered all the part of study design very nicely. In a 20-minute session, I think she has done fantastic job. So no nothing to add.
And very simplified way so that it is very easy to understand how to, sort of categorize those studies. So that was amazing.
So most of our viewers are going to be the PGs and fellows and junior consultants. What would be the advice that you give it to them? Because our presentation has to be more practical so that people can just watch this program and take home some message. What could be the take home message for our people?
Sharmila, if you can just, in couple of lines, you can just that which study, which design they should take. I think that would be a very nice way of concluding.
That's true. That's true. Actually, now these PGs, they have this research, the dissertation that they have to do. So in most of them have some kind of formal training in the research training, research methodology workshops. So all of that actually kind of helps. That becomes part of their curriculum also, to know basics about research methodology. But however it is, whenever you go for such sessions, it appears very fresh and you seem to be understanding everything. But unless and until we really apply it in our routine um, practice as to taking up a study, it would be just a simple, retrospective study also. The way that we conduct the study, the way that we put the results, the tables, and how we read these articles, and basically dissecting the article is that's very good that we are having such journal clips, because it really gives a good exercise for the mind to understand how to put things in the right perspective. And yeah, I think it is just a learning process, and it will just evolve. As you read more and more, you would evolve for it.
Yeah, so thank you so much. And I'm sure that whoever has been watching or whoever is going to watch this program, hope this program is useful for you. Please do send your valuable feedbacks to us in our email so that we can apply that and then we can improve our program. So thank you once again to the presenters, Dr. Sharmila, Dr. Meenakshi Dogra, and mentor, Dr. Meena, and the moderators, Dr. Sushma and Rajul, for being with us today. Thank you so much and good night.
Thank
Thank
you, sir. Thank you.
Thank you.
Thank you. See you all. Bye.
Bye bye.